morning, everyone. I'm David Lee. I'm from Stanford University. I'm the director of the Cath Lab at Stanford, and I'm the moderator for this session. I'm pleased to have Jim Duran, Michelle Moss, and Kevin Bobrowski here with me to answer some questions as part of the live QA. So I'm going to start maybe with Jim. I think one of the things that we struggle with is how much training for EKG interpretation is the right amount for your EMS personnel. And I'm sure Michelle probably has an opinion on this as well. But is it just basic training? Do they need, is there a set goal in terms of trying to create a EKG interpretation program for all of your EMS personnel? What's the right answer there? I'm not sure there is. I'm just asking, I guess, out of curiosity more than anything else.
Well, there is no right answer, and it all depends on the system. But fundamental training is very important, and to know where to apply the 12 leads, how to acquire the 12 lead, and then how to interpret it. And I think a lot of times, we utilize the computer interpretation on the 12 lead as the right interpretation, and that's not necessarily the case. So the more that the practitioner knows and in the interpretation and what they mean, the better patient.
Okay, Michelle, any comments there?
Yeah, I would agree with James. I think that in our system, what we see is a much higher EKG over triage than we do our paramedics. So our paramedics, I think, are picking up the subtleties very well. Where I think the additional training is important is in identifying those things that are causing the machine to over triage. So I think more training specific to those things is probably the best use of resources.
Before I move on, I have a question for Kevin coming up here in just a moment, but maybe again to ask the two of you, one of the issues in the chat or the QA was really about false positives. It's a real problem. Depending on the literature you look at, it's anywhere between 20 and 40%. And I think how do we get around that? Are there new technologies on the horizon? What can we do to sort of limit because this costs a lot of money actually, right, to activate a cath lab and activate the whole system to get things moving for a potential STEMI that turns out to be not a STEMI. How do we approach this in the near future and maybe further beyond?
Yeah, I think there's a lot of challenges with that. I think that's one of the reasons why we so closely monitor our over and under triage, because like you say, the data will show anywhere from 20 to 40%. I think it depends on what you're actually measuring and where you're getting your data to measure it. If we look just at our registry data, we wouldn't actually capture a lot of EMS STEMIs that actually are found on the PCR, but then at the hospital, they disappear because they're not really a STEMI when they get there. So I think where you're getting your data from can determine whether it's 20% or 40% that you're looking at. I think that we have tried to address those things that are addressable, things like skin prep, things like making sure that the EKGs are new, that they're not preloaded at the beginning of the day. All those sorts of things I think are helping. But the machine overinterpretation, we've looked at Zoll versus LifePak to see if there's a difference, if one is overdoing more so than the other. I don't know. I think that's more a question for the machine manufacturers when it comes to what they're capturing. I mean, what we're seeing is a lot of bundle branch blocks obviously are getting picked up as STEMIs. And I don't know if we'll ever get around that. So I think it's addressing those things that you can identify and fixing those.
Thank you for that answer. Kevin, let's turn to rehab. We know as cardiologists, it's super important. And I think one of the questions that comes up is from the EMS side, how do they support this push to get people into rehab? I think it's an important issue because it really does tangibly decrease the problems after a STEMI. How do we get there from the EMS side? Is there a way to approach that?
Well, I'm not sure exactly for the EMS standpoint. Once patients undergo a STEMI or PCI, our nurse practitioners get involved right away and get the referrals sent in. We are able to capture probably greater than 80% of patients in our program within the first 3 months of an acute coronary syndrome. But we do occasionally miss some, and so we rely on our individual physicians or some database mechanisms that we have to identify patients. But I'm not aware of any involvement from the EMS system directly in getting patients into this kind of a program.
I think it is important. And one of the questions in the chat was an interesting one because, our EMS personnel not only deal with STEMI, obviously, they deal with a lot of other things. What about heart failure? Because, it may not be related to a STEMI, but one of the questions was about addressing heart failure rehab. And is there a difference between heart failure rehab and MI rehab?
There is a bit of a difference in that heart failure rehab, I think they benefit more from the exercise component of the rehab. And once they're stabilized, once their heart failure is in a good management, and they probably have already received the guidance as far as diet and smoking restrictions and all that. But oftentimes the exercise component gets overlooked, and this is something that maybe a few years or several years after an acute coronary syndrome needs to be addressed. And they're making a referral to rehab and getting a treadmill to see what their baseline exercise tolerance is really can make a difference. And I think of all the patients in rehab, I think these are the minority, but I think that there should be a greater focus on getting these patients in to rehab. I think they would really benefit.
Yeah, I think there is a move, and this is where the electronic medical systems and the records can be helpful for creating order sets and so forth. We have it routinely for our STEMI and non-STEMI patients, as well as our heart failure patients at Stanford. I want to go back. There's a question in the QA really directed toward Michelle, really, about what made you get with the guidelines rather than some other system?
There really weren't a lot of options that were fleshed out enough to actually be of value to us. Like I say, we've done well for years with our Excel spreadsheet, so we knew what data elements that we needed. There were really no products on the market that gave us exactly what we wanted. The AHA was as close to it as we could get. We did look at building an in-house program to do it. That's still on the table. Image Trend, their system wasn't really fleshed out very well yet in terms of being ready to just implement. So really, it was a process of eliminating those that weren't quite ready, and AHA was the only one with a market-ready product for us to use.
Thank you. And Jim, I have a couple questions for you too about the way that Michelle and others have sort of set up the whole timeline and then trying to understand where we can do better. How do you get the feedback back to the crews for your pre-hospital engagement? Do you sit them down at the end of the month, or how do you give them the feedback that they want and need about not only the outcomes, but also the process and where the process improvement pieces can come into play?
Well, and then that's the difficult part. And so there are ways we can do quarterly STEMI meetings, and where you get all the providers together and the hospitals and then discuss the data and then getting it back. But there's also commercial data hubs out there, which you can actually tie into the EPCR to the hospital and share data bidirectionally, which is really nice because it gives you fairly close not instant feedback, but as soon as they input the data, it could be sent back to the crews to let them know if the patient was a positive STEMI or not.
How do they respond though when, I'm curious about this because we do the same thing, we straddle 2 counties, but we give the crews feedback and they're always excited to hear what happens. I presume that most EMS first responders are very excited to hear whether it was a good or a bad outcome and know what the door to balloon times are. Are those the kinds of data that you share with your providers?
Yes, I think that's really, really important because then it emphasizes the work that they're doing. Because if they, for example, if they do a 12 lead and they transmit it and then the hospital or the emergency department doesn't use it, it decreases their excitement about doing 12 leads, and they're saying, well, why do we do it when nobody does it? But if they can show that that 12 lead captured in the field actually reduces door to reperfusion time, it re-emphasizes the work that they do. And so you get excited about it and you feel like you're making a difference.
Great. And one question that came up in the chat, and actually any of you can answer this, is about the machine reads. So is there a way to triage when to do an EKG before you get to the hospital? Are there guidelines for this about teasing out those patients that may be most appropriate for EKG utilization? Because we know the more we do, the more we're going to find, for good, for better, or for worse, right? So how do we manage that? Maybe Michelle wants to start answering that question.
Yeah, we actually just re-reviewed our 12 lead policy, which has been in effect for years. And I made some significant modifications to it in an effort to lessen the number of 12 leads that are done, because there are a lot of 12 leads done. And like you say, that can be for better or worse. So we were very specific about the criteria for patients that should get a 12 lead, that included some of those, the postmenopausal female weird symptoms, we included some of that in there, the weakness, those sorts of things. But we were just trying to provide a list of, these are kind of the patients that you want to focus those efforts on. And I think it's kind of too new to tell at this point. We just did those changes to the policy. But again, the guidance is that not every patient should get a 12 lead, and that it should be very specific. So we're hoping to reduce actually the number of 12 leads and put them on the more appropriate patients. And then it also talks about how often to repeat that, when to repeat your 12 lead, and that's based primarily on symptomology and how the patient's doing. We also make a point to drive that 12 leads are done before nitro is started, so that we're sure to get what that's looking like before any treatment has been provided.
Going to Kevin real quick. Do you care whether it's an anterior infarct or an inferior infarct or a lateral wall infarct before these patients hit rehab?
No, that doesn't matter. I mean, they're all candidates for rehab. I mean, an inferior infarct can be, just as lethal as an anterior infarct, and sometimes, more so, harder to recover from. So there's not a distinction as far as rehab goes.
Okay, thank you for clarifying that. Back to Jim. One of the questions in the chat /QA is about how do you reward the EMS personnel and the medics if the machine doesn't read it correctly, and the medics actually will activate the STEMI if appropriate. I'm having a little chuckle here, because if the medic is correct and the machine isn't, we give them a pound of bacon. It's called the bacon award. and I'm sure Kevin wouldn't be super happy about that, nor I as a cardiologist. But do you have ways to sort of reward people for the good work that they're doing internally? How does that work for the pre-hospital pieces of this?
Well, I think it's pride on doing a good job. And again, the 12 lead is just a tool, and also it's only as good as the data that you put into it. So if you prep the skin, you put the leads in the right location, you actually can diminish the false positives. And not trying to do a 12 lead in a moving vehicle, and you look at artifact and making sure that the 12 lead is really clean prior to sending it to the hospital. Ways to give people credit for doing a great job is probably, I think the best thing is from their medical director. Yeah. Is a note from the medical director saying, wow, you really picked this up, congratulations, and this is it's great for patient care.
Great. And Michelle, quick question for you about transfers, managing the data for transfers for your STEMI hospitals. How do you manage that data set? It's kind of challenging, I think, to have a feeder hospital and then also and go through the politics of having them relinquish those patients to a PCI center. How do you manage that data, and how do you manage that relationship?
We throw it on our STEMI receiving centers and make them do it. That is a big part of the data set that is in the AHA registry. So our STEMI receiving centers are required to get that data from those facilities. Then we also use a tool to, for all of the STEMI referral hospitals that send patients to a STEMI receiving center, those STEMI receiving centers by policy with us are required to give feedback to those STEMI referral hospitals about how each one of those patients were managed and how they were handled once they got to the STEMI receiving center, and ultimately what their outcome was. In addition to that, in the last month, I created a report that we send directly to the STEMI referral hospitals, which has been very eye-opening to them, that talks about their time to transfer, how many patients got thrombolytics prior to transfer, their time to 12 lead. And they've been very interested in getting that data. So it gives them something to focus on and do a better job with. It's a challenge in our area. We do have limited CCT resources. We do have a big geographic area. So getting patients to PCI in less than 120 minutes for those transfers it's a big challenge. So any improvement we can get on that is what we're working towards.
Maybe one final quick thing, because we're going to have to go off the chat here in about 1 minute. What do you think about new technologies? And they're really old technologies. What about giving the EMS folks a first responders an echo? Would that be helpful, not helpful? Especially for those maybe who have an equivocal EKG. Thoughts?
If you're asking me, I mean, it's one of those things that from a pre-hospital perspective, anything that slows us down in getting the patient to where they need to go has its own challenges with it. And again, applying it to the right patients, we have a big geographical area, so we're a little different than some, but I'm not sure how much of an advantage that would be and how much our hospitals would rely on the information that comes from those sorts of, pre-hospital studies.
I think also repeating an EKG in the ambulance might be helpful. Sometimes you get very subtle EKG changes initially, and we've seen many times when somebody arrives, they've had very equivocal findings, but then they have, really predominant ST elevation in the entry leads when they hit the ER. So I don't know, an echo might be hard to, in a moving ambulance, to make a good assessment and interpretation of wall motion. But, repeating serial EKGs also might be helpful.
Jim, any comments?
Well, I think, again, like Michelle said, anything that delays the patient getting to the emergency department is not good. And you got to look at the frequency of utilizing that technology on the patients, and to be a very skilled practitioner at it to get quality data that is going to be meaningful to the receiving facility.
Kevin, Michelle, Jim, thank you so much for your presentations and joining me for the live QA. I can see that there's a lot of other questions here in the QA. We will try and get to those and answer as many as we can before the end of the day today. So thanks, everybody. We'll go on break now till 9:25. Which is about 9 minutes from now. So we'll see everybody again at 9:25 for the next session, which is entitled Updates in STEMI Management. Thanks, everybody.
Thank you.